Well, it is a real distinct pleasure to be here, and I thank you all very much for your attention. I'm going to talk to you a little bit about my experience with robotics. So let's get this on the slideshow there. I consider myself one lucky dude. I'm a lucky guy. And so you might say to me, well, how lucky are you?
How lucky are you?
Well, since you asked, I asked a girl 3 times to marry me before she said yes. I hunted 9 days this fall without seeing a single buck, but I did survive getting stalked by a cougar. I didn't match at my first choice, but I ended up at Johns Hopkins with Dr. Kostwick, Riley, Kabash, Cohen, Gokazalin, Long, and the rest. And I had a great training. And despite my early prior negative experiences with some of the navigation systems, my passion for patient safety has led me to become the first robotic spinal surgeon in the Pacific Northwest. So I greatly appreciate the opportunity to spend some time with you all going over what I'll describe as a YouTube-style how-to video on Generation 2 robotic lumbar fusions. Thank you, Dr. Drazen and distinguished faculty for including me here today. So let's start off with the single-level primary L4-5 TLIF for spondylolisthesis. As an aside, I'm often told by surgeons, I can see where that there robotic technology can help you younger deformity guys, but I paste 10,000 screws, I don't do big constructs, it'll just slow me down. Well, I am pleased to tell you that we have done the research on all of our single-level primary L4-5 grade 1 spondylolisthesis, several hundred cases without a robot, with the Gen 1 robot, and with a Gen 2 robot. Currently, the statistical analysis is being done on this, and we'll publish it later this coming year. But I can tell you that the data is pretty overwhelming. We're faster going from 0 robot to Gen 1 robot, and we're substantially faster going from Gen 1 to Gen 2. So you've heard people say, well, navigation slows you down. That may be true. Robotics is not the case. Now, getting back into focus, once appropriate conservative treatments have been done and failed, once you have all your scope data and your fitness for surgery criteria met, 2 plugs for Washingtonian programs. Once the risks and benefits of surgery have been discussed and informed consent obtained, then we can proceed on to surgery. At this stage, we still get a preoperative CT scan obtained with appropriate cuts to the designated area. And then this is uploaded into the robot computer, or rather the computer that drives the robot. This allows us to plan these screws days or weeks in advance of actually doing the surgery. We can optimize our trajectory, we know our length, we know our depth, we know our width, we know what instruments we're going to use, so we don't have to bring up pan after pan after pan of set after set and wash set after set after set of all these screws that we're not going to use. It also allows us to go into the operating room, and the whole reason we're there in the operating room is to help the patient. So we can get into the operating room, and instead of spending however much time it takes you focusing on, well, I'm going to put a screw here, and I got to figure it out with the X-ray tech or the unshielded CAT scan and all this. You get your hardware done. All the surgery's mentally been done beforehand. You're just executing it. You're putting it where you place it. And then you spend your time doing the whole reason that you're there, to help the patient. You do the decompression. You correct the deformity. And you're doing this with a fresh mind and a fresh body. And you're not having to use your energy yelling at a X-ray tech or trying to figure out how you re-register. It's done. And that has freed me up. And it's actually been probably the most unanticipated but most concrete and fundamental advantage of this experience I've had with robotics, is I'm now focusing on correcting the problem primarily. I'm there to help the patient, and I don't have to worry about these tools as much as I did. And I think Dr. Chapman wisely said, well, aren't we facilitating non-surgeons to do this? It's not that you're not putting in the mental energy and that you're not putting your focus there, it's that you've done it in advance. You've done it outside of the operating room. You're not burning OR time doing this in the operating room. You do it while your kid's at ballet class, or your daughter's at a tennis tournament, or the times that you have free to sit with your warm, lovely computer. And it actually doesn't take that long. It's pretty easy to do. It's a drag and drop type phenomena. You literally, I want to do an L4 screw, boom, boom, and then I can adjust it where it is with micro motion. And that allows you to plan for tight pedicles, for difficult pedicles. This happens to be just a video that we shot earlier this week, but it shows how you can scroll through the pedicle and really maximize the cortical bone. In the last talk we heard about, well, I want to know what the optimal trajectory is. Well, in an osteoporotic patient, you're going to want to get as much of that cortical bone as possible. You want to feel comfortable putting in the maximum pedicle. You want the maximum screw for the marginal pedicle. So we can plan our trajectories where they intersect with the skin to minimize our incisions and also to allow for proper rod alignment. And this takes very little time with the Gen 2 technology. It's very, very quick. Here's my standard setup for a TLIF. You'll notice that we have obviously the patient in the center, patient-centered care. We have anesthesia at the head, neuromonitoring at the 10 o'clock position, the fluoro machine at the 2 o'clock position, Bovie Burr machines at the 5 o'clock, the tech table and equipment spanning 6 o'clock to 8 o'clock. The robot enters from 9 o'clock, surgeon at the left and the assist across at the right. And so if you were to look on top of this, basically the robot's going to come in here, surgeon's here, the assist is standing in front of Bob, one-shot Bob we call him. He can take an x-ray picture perfect every time. It's really amazing. Not everybody's like that. So then the approach to the spine is done in your usual and typical manner. You can do that minimally invasively, you can do it maximally invasively, but you're going to approach the spine. You're then going to place a reference marker, and in this case on the left we have the posterior iliac crest being done for the reference marker. You can also place that on the lowest spinous process that you've exposed. So these are the two ways you can mount that. The reference markers are placed. You then are going to take an AP and a lateral shot of the area that you're working and merge that with the robot. And you'll notice that it's a little bit different than the fluoro shots you're used to seeing because we have reference markers in the array, but that is part of the mechanism that it uses to merge with the CAT scan before. And so now that the reference views, the AP and lateral are taken and sent to the robot device is going to recognize what levels it's at, put your screws on it, and then ask for your verification. And I'll try to point this out to you. What's happening on this video is that it's alternating between the fluoro shot and the CT scan, kind of oscillating back and forth, and allows you to see how evenly they match up. And if you're happy with the match, then you can verify it yourself. So as a surgeon, you're still in control and very much in charge of where the screws go. The robot arm is then sent to the farthest screw position. And what I mean by that is if we're doing, say, an L2 to L5 construct, you would send it to L2 first and then work yourself down in a serpentine manner. And the reason for that is that these screws, whatever screw you're using, they all have similar biomechanics. They're very powerful. They grip the bone very well. And as you're inserting it, or even just using the tap, you're actually going to slightly pull the body on that Jackson table towards the screwdriver. And that effect is magnified the farther you get away and the more you do it. So I would strongly encourage you to start farther away and work yourself closer and alternate from side to side as you come down. We then drill to a predetermined depth through the cannula that'll stop itself. I usually use the tap. I do under tap my screws and then place the screw. We then move on to the next trajectory following that serpentine pattern. So this video shows this in action. If you notice, you can see on the monitor where the navigation is showing you where the screw, or in that case the drill was. Now here's the tap going in. And again, you can tap down to the correct depth. And then this will be followed by a screw. It does not take a terrible amount of time. although there's the self-consciousness part of watching yourself do it. And then the screw is going in, inserted in the trajectory that you had previously planned. Spine surgeons needing external validation, we get a check mark showing us that we accomplished what we thought we were going to accomplish, and then we're then able to move on to the next screw. Since Gen 2 units are not physically attached to the patient or to the bed, once instrumentation is complete, the robot can be taken out of the operating room and moved to another OR, utilized by another surgeon on another case, while you do your decompression and the rest of your case. Single position lateral surgery is very similar. It follows a similar pattern, but there are some idiosyncrasies specific to that, and I'm going to cover those right now. So for the room layout, we want to start again with the most important person in the room. The patient is in the center on an AMSCO table. We then have our Gen 2 robot. Anesthesia, our most precious non-renewable resource, and I'm not just saying that because my wife's an anesthesiologist. We have our neuromonitoring personnel, our fluoro unit, and then our surgery tech and tools. Just to contrast this from my normal layout for a TLIF, we have moved the fluoro to the opposite side of the room and the robot to the opposite side of the room. And you'll see once we have a live picture why that makes sense. My workflow, I like to get the patient asleep and wired up and in the lateral position on the AMSCO bed. I'll adjust the bed and secure the patient and take our fluoro shots there to confirm that we do indeed have access. We'll prep and drape, recheck the fluoro shots, place our screws, do a lateral, and place the rods. That's my workflow. It is not the only workflow, but it's the one that has worked well for me. So the initial setup, lateral decubitus, we're using an axillary roll, SCDs on both of the lower extremities, an upper body warmer to keep the upper body warmer, and then we use warmed blankets on the lower extremities. We wire up before positioning. We secure the patient at the table, check those films, make sure we have access, and we have the fluoro tech actually mark on the floor and on the machine where they need to go to get those perfect views back and forth so that we're not struggling to teach the next person that comes in when they take their break. We then prep and drape. At my institution, we do 2 preps, each 3 minutes apart to make sure they're fully dry. I use a universal drape, and I drape really wide. I'm basically belly button on this side, all the way past the spinous processes on this side. We want to have full access to be able to get our trajectories. And we do our formal timeout, recheck our AP and lateral, and now if there's a problem, if things have shifted, now is the time to adjust. Once we're confident with that, we'll place our DRB, or our reference balls. You'll notice that now they're going on the posterior iliac crest that is on the upward side of the room. The elevated iliac crest is what I meant to say. And then I do prefer to place the screws first. That's my personal preference, and then do the lateral, and then place the rods. It is possible to do the lateral first if you like, but this is the way I prefer. And this is a video just demonstrating what it's like to send the arm and then drill through the lateral position. The robot really does not care what position the patient is as far as where it sends the arm. It just needs to know where the patient is in space, and it does that very nicely. And you can see we're successfully passing the drill down our trajectory, in this case with one hand. Then go on to do the lateral arthrodesis. I will recheck the fluoro images at this point, secure the arm of the retractor to the inferior portion of the table. At this point, we don't have an incision here, so we'll use a lot of local anesthesia to preemptively anesthetize the person there. Sharply incise the skin, dissect through the muscle and fascia, bipolar or retroperitoneal fascia, visualize the psoas, and place our neuromonitoring probe. We then are going to want to map out that safe corridor, and I can't emphasize this enough on laterals. You really have to have a great communication between your neuromonitoring tech and the surgeon. This is not a time to be playing AC/DC or the latest pop hits on the radio. It's a really time to have an intimate conversation with that neuromonitoring tech so that everybody's at the top of their game. If you're having low thresholds, you got to readjust. You got to map out a safe corridor. But once you have that, you can add on your blades, get your retractor in place, and as you expand that corridor, you want to start the timer. There's quite a bit of data showing that the longer these retractors are in, the more likely you are to end up with quadriceps palsy. And so we start a timer, and 30 minutes is our max at my institution. Then do a lateral arthrodesis, to complete discectomy, do your disc preparation, do your grafting. I choose to use expandable devices. I find them to be a powerful tool for this. So you'd put your device in and expand it, backfill the graft, and then it's time to do your rods. And so we would size the rods, pass the rods, compress if applicable, secure the end caps, and then expand the cage. And so this is just a picture showing what that actually looks like, where we've passing our rod, securing it with the end cap through these tiny incisions. And you can end up with a pretty reasonable construct there. Again, you're going to want to backfill the graft, re-expand if you need to, and you can do your standard closure. When I withdraw those retractors, I'm very careful to make sure that we've gotten all the bleeders on those muscle layers as we come out. And I have done it the other way, where you do the lateral first. The keys with this, and with any of the registration-based navigation, in this case robotics, is you can't violate the end plate. The end plate is really necessary for the computer to recognize where it is. So if you do this, you're fine as long as you don't mess with the end plate. Once you get in the end plate, it's going to be hard for these machines to recognize what the bone was compared to the CAT scan. So post-operative instructions for my patients, I have them in a brace when they're up and moving for 12 weeks. We avoid the BLTs, bending, lifting, twisting. They can shower, but I don't want them to immerse it until the 2-week post-op visit that I can see that the wound is healed. And I require that they walk more and more every day. In Washington State, we don't do fusions on patients that are smoking, but we'd say no nicotine at all, no vaping, no chewing, and any of that. So before my time's up, let me leave you with some tips and pearls in regards to robotic-assisted single-position lateral arthrodesis. Use a timer. Make sure that you're below that 30-minute retractor time in the lateral position. Get your imaging marked in before prepping and draping. I would strongly encourage avoiding using monopolar electrocautery. You're going to plan where those towers are coming out of the skin so you can make the least impressive incision posteriorly. I'm a big fan of preemptive analgesia, so a lot of local anesthetic, medicines you can give them beforehand, and then same-day physical therapy for ambulation. I also personally try to avoid a Foley with these patients as well. So if I could summarize, robotic surgery is rapidly becoming accepted as the community standard of care for instrumented spinal fusion surgery. Our previous speaker said it's not quite there. He predicted 2 years. Well, 3 years ago, I predicted that it would be the standard of care in 5 years. I think we're both saying the same things. It's happening. With care and attention paid to preoperative planning and the OR layout, converting from freehand and navigation to a Gen 2 robotic surgery is well within the capabilities of any who claim the title of spinal surgeon. I look forward to assisting you guys in the lab later today. We'll go over some of these techniques. And thank you very much for your attention. Are there any questions that I can address at this time? Please.
Yes, that's very interesting. One of the issues when you're doing a lateral, at least when I do it, is every once in a while I have to bend the table just a little bit, try not to. But with the robotics and then your rods posteriorly, I'm under the impression you don't have to bend them, you don't want to move the table very much.
Right, so the question was that sometimes when you're doing a lateral, it's helpful to crack the table a little bit more and make some adjustments there. That would matter if you were doing your screws later, which is part of the reason why I like doing my screws first. I'm using the robot, the precision is there, before I've done any horking around on the patient, before we make any mechanical changes to the bed. The rods are going to be in basically the same alignment, even with a little crack on the table there, once the screws are in. So I think passing the rods, it might make it a little more challenging if you really horked on the patient, but the screw precision will be there by doing it at first. So I think for your technique, the way you choose to do the laterals, you would favor placing the screws first, then doing the lateral, and then passing the rods, and you would not run into a problem that way. There was another question? Yes, sir?
Can you hear me? For these single position laterals, are you and others who are doing it, are you just relying on indirect decompression? Are you doing it for foraminal stenosis? Or are you saying, hey, I'm going to stretch the ligament and hopefully there's not enough subsidence later on? Or are you basing it, doing it for certain cases only?
So there are several reasons why I like to do laterals. And there are several reasons why I try to avoid doing laterals. And I would say that my perfect lateral patient would be a patient that has predominantly L3, L4, or L2, L3 pathology. We know that quad palsies tend to occur at the L4, L5 level. They can occur at any of the levels, but they're really predominantly at L4, L5. So I will actively avoid doing L4, L5 unless there's some compelling reason to do it from the side. At 3, 4, I think it's a great place to do it. L2, L3, very accessible, very easy. The ideal patient would have maybe a low-grade spondylolisthesis or a sort of one of those grapes to raisin kind of disc bulges where they're going back, where ligamentotaxis would be expected to adequately decompress the central canal and the foramen. And that's predominantly a tool that you're going to use. You do have the ability to realign the bones there with asymmetric placement of the screws, or you can even use Schantz pins to reduce the spondy if you want. So I think that those would be the candidates that I would think would be really good for this. There's also, in revision surgery, if someone's had extensive multiple laminectomies, they still have significant foraminal stenosis, and maybe there was a pseudomeningocele in the back or something that's really makes it tiger territory to be in that area. It's kind of nice to be able to stretch it out from up front. So those patients are good, but then you'd augment it with some posterior procedure as well. So you can use it in combo or standalone. I would say the single position ones for me are generally going to be patients that have pathology predominantly at the L2 to L4 region. It's usually going to be on the milder side, foraminal stenosis. If they have severe central stenosis, this probably isn't going to be enough. And then I also like the patients to have a big belly. If their BMI is 39.4, so they just squeaked in under our 40 BMI spot, and it's all here, you put them on the table, and it's just out of the way. And so those patients are the ones that I really like. Does that answer your question? Okay.
Well, in general, I guess based on experience, I've probably done about, 500 L4-5s in that general. It's just one of those things, you get a learning curve and experience with that. It's not bad over there either. But in general, there's about 25% subsidence rate. Even if you stretch the ligament and you haven't done a central decompression, you end up doing a redo. But I think foraminal stenosis works a lot better.
Yeah, I'm not poo-pooing the 4-5s. I think it can work out well. But if I'm given a choice of going posterior or going lateral, I lean posterior at 4-5, even on revisions. Whereas at L3-4, I'm much more liberal about that. But I think part of that also is, we have to be really diligent about mapping out where we are and really diligent about posterior blade retractor time. And so having the excellent neuromonitoring tech that you can count, and then the timer. Anybody else?
I'll just add to that, that I do oblique at 4-5, and that seems to be great, so no issue.
All right, well, thank you guys very, very much. I really appreciate it.